here at Virginia Beach General Hospital to talk to you about hip pain in young and old patients. And I'm here with my managing partner, Dr. Chris Ellingson, who is a specialist in young hips.
Hi, again, I'm Chris Ellingson. Glad you could all join us. Today, we're here to talk about both arthritic and non-arthritic hip conditions. Dr. Lambert is going to be focusing on the hip arthritis and the technology we have available for addressing that. I'm going to give you a brief introduction to some of the non-arthritis hip conditions that we see and treat in our clinic. We're coming to you from an operating room at Virginia Beach General Hospital with Centera, and we're glad you could join us. In my practice, I'm a sports medicine orthopedic surgeon, and so my focus in my practice is in athletic type of injuries. Now, obviously, not everyone is an athlete in terms of playing a sport, but there's a lot of injuries we take care of in terms of overuse type of an injury, just from daily activities, gardening, taking care of the kids, doing other sporting type of activities. And the hip pain patient can be a difficult patient to diagnose accurately because there's a lot of things around the hip joint that can hurt, both anterior, lateral, and posterior. So in my practice, we evaluate patients for conditions such as hip flexor tendinitis, which is oftentimes an anterior pain, hip labral tears, which is anterior, lateral pain, oftentimes conditions such as greater trochanteric bursitis or gluteus medius tendinitis or tendinosis. Posterior pain can be related to conditions such as piriformis syndrome, SI joint issues, and so we're available to obviously evaluate and treat patients. The majority of patients that we treat are able to be helped with non-hospital measures, including considerations for physical therapy and or injections. There are some surgical conditions that I take care of specifically, that being hip labral tears, which are oftentimes accompanied by a condition called femoral acetabular impingement or hip impingement. And for that condition, we can do surgery such as a hip arthroscopy. For those patients that have arthritic type of conditions, Dr. Lambert is one of our total joint specialists, and I'll turn it over to him to discuss some of the treatments and technology available for total hip arthroplasty.
Thanks, Chris. I'm going to take my mask off so you can hear me a little better. We are in an operating room. We are observing COVID protocols. I think Dr. Ellingson has to step out for a surgery, so I'm going to take it from here. I just want to review who we are at OrthoVirginia. We are the largest practice in the state of Virginia for orthopedic surgeons. Some of you may remember us as Virginia Institute for Sports Medicine, which was our group before we merged with OrthoVirginia. And now we're part of a much bigger group. We still have the same practice here in Virginia Beach in a brand new office about a block away. We also have offices in Richmond, Northern Virginia, Lynchburg, and Blacksburg coming soon. Okay, so before we go any farther, if you like what you hear, please click the share button and share it with your friends. All right, now I'd like to get started talking about hip surgery. Before I do that, I want to tell you that most of the patients that I treat in the office here at OrthoVirginia are treated without surgery. What I mean by that, we use simple anti-inflammatory medications, physical therapy, sometimes some injections to help with the hip arthritis. If that doesn't work in a small subset of patients, we end up doing a surgery. And that's what I'm going to talk to you about today, is a small subset of patients that need surgery. And that's why we're here at Virginia Beach General Hospital. The room that we're standing in, we're going to give you a little broader view of that here right now, is a brand new operating room, less than a year old. So as Rich pans back on the camera, the first thing you'll notice is that this room is big. It has to be big to incorporate all the things and technology that we have. So one of the things that I would like you to see is the monitors here on the wall that we have. These are 3 flat screen monitors that allow us to show patient information during the surgery and share it with the entire surgical team. In addition, we have state-of-the-art lighting, and this is a striker suite that has multiple things I could talk about all day, but we're going to mostly talk about the specifics of hip replacement today. Okay, so modern hip replacement has been around a long time. Matter of fact, it's been around longer than I have. The first one was done in England in 1962. A lot has changed since then. Patients used to be in the hospital for weeks afterwards. Here at Virginia Beach General, we do hundreds of these a year. Now, most of my patients go home the next day after a hip replacement. It's still big surgery, but I'm going to show you today about some of the pieces of technology that have made the recovery for our patients a little better after a hip replacement. The first thing I'd like to show you is this table that I'm using to have my notes on. We're going to pan back a little bit to take a look at it. This table is called a HANA table, H-A-N-A. This is made out of carbon fiber, which means we can x-ray right through it during the surgery. We couldn't do that before. The previous tables were made out of metal, which you couldn't x-ray through. By being able to x-ray through it, allows us to be much more accurate. In addition, during the surgery, I can move the patient's leg. I'm going to have an assistant demonstrate here what we mean by that. During the surgery, the patient's leg is rotated, dropped to the floor, or lowered to the floor, to allow me to have access to the hip.
Apologies for that.
All right, I think we're back. So this technology of the hip allows me to do an anterior approach total hip replacement. So anterior approach is what I do for hip replacement, and what that is an incision in the front of the hip, where we don't cut the muscles, we just separate it. And by doing that, that allows the patient to recover much quicker. As I said, most of our patients are up the same day, walking on their newly replaced hip, and the large majority go home the next day. Some even go home the same day. And this is because of the anterior approach. Like I said, this table is radiolucid, meaning we can x-ray right through it. So that allows us to use another piece of technology I'd like to demonstrate today, and that's the VELOS hip navigation, which is a product of the Johnson & Johnson company. And we're going to demonstrate over here at the monitor. This is a preoperative x-ray of the patient before they've had surgery. This is the left hip. It has a lot of arthritis in it. There are cysts in the acetabulum. There are osteophytes, and there is a narrowing of the joint space. These are all typical of arthritis. This is a patient that has already failed anti-inflammatory medications, physical therapy, and weight loss, and we're here to do a hip replacement on this patient. So before the surgery, we take this x-ray, and then we put the preoperative plan on there. So these little tracings are showing the size of the implants that I intend to use during the surgery, and they're accurate to the millimeter. In addition, it measures some things that we use during the surgery, such as the leg length. Believe it or not, during a hip replacement, I can lengthen the leg or shorten the leg, depending on what needs to be done for that particular patient. And this software helps us to get it down to the millimeter. So once we have the preoperative plan completed, then we do put the parts into the patient. So I'm going to demonstrate the parts that we're using in hip replacement today. Here is an example of an acetabular component. The acetabulum is the socket side of the total hip replacement. It's made out of two pieces. One piece is titanium, and the other piece is plastic. And this is the new bearing surface where cartilage used to be plastic and now sits. Okay? So this part is placed into the pelvis, and this roughened titanium surface allows it to stick into the pelvis. And the position that I put it in is very important. So during the surgery, this is an inserter device that you simply screw on to the acetabular component, and I get ready to put it into the patient. And when we put it into the patient, we're going to demonstrate over here what our hip navigation system allows us to do. Previously, I would put it in and use my best judgment to get it in the right position. Now I have some objective feedback. Specifically, I have imaging that can tell me exactly how many degrees, and we can change it to 1 degree difference depending on what best suits that particular patient. This is extremely accurate and takes all the guesswork out of it. Once the acetabular component is in the patient, we move on to the second part. So the second part involves putting in this femoral implant. This is also made out of titanium. It looks a little bit like a spike that goes into the femur bone. It has two parts. The titanium part, it has a rough coating which the bone grows into, and the ball. This is made out of ceramic. And they connect together like this. And the final implant is metal on or ceramic on plastic, like this. Okay? So how do we get the metal part into the patient's femur bone. I have a demonstration to show another piece of technology which is called the Concise Automated Impactor. So this is the femoral implant. Prior to putting it in, this is a model of a bone. So this is what we call saw bones. It's a pretend bone that we use for practice. But assume this is a real patient. Normally, several years ago, we would use something called a brooch. Similar size, similar shape to the actual implant. Helps me hollow out a hole in the bone marrow to put the implant. This is how it used to be done. We put it down, and we would hit it with a sterile mallet, like this. It takes a lot of practice to learn how to hit it, not too hard so as to break the bone, and not too loose so the implant is still loose. Each blow should be the exact same amount. Very difficult to do with a manual swing. In addition, the flow can be off-center. You get it not flat on, it can alter the mechanics of the hip. This new device, which is called the Concise, which is an automated impactor, has the brooch connected to it, and by pulling the trigger, I deliver an impacting force the same amount each time, similar to a jackhammer. And when you hold the trigger, it will deliver 6 blows in a second. So when we're putting it in, this is a much more precise way to do it. So during the surgery, this is all sterile. This again is the femur. Put it in the femur like this, and push the button like this. And then we detach here. And then the top part of the trowel goes on like this. So that's in the patient's body. And then we put the hip back together with the socket. And then we bring in the fluoroscopy machine to take a picture. Once we have the picture, come on over here to the monitor and I'll demonstrate what we look at. Mind you, the patient's still in the operating room, still asleep. So this is a picture of the parts that we just put into the patient, which shows the leg length and the offset. And we're going to start with where they were beforehand. This was the native hip, and we have some lines drawn on there with some points. And then we're going to slide it over with an overlay of the current hip. And you can see how the points have moved a little bit. We want to recreate exactly what we want. If the patient's leg was the same length before, we keep it that way. If it was short, then we lengthen it a little bit. And that's what this Bell's hip navigation allows me to do in hip replacements, and be a lot more precise with what we're doing. So that's what we use today in the operating room for hip replacement. Before I forget, if anyone has any questions, feel free to type them in, and we'll try to get them answered during the time we have together to talk about hip pain. My partner, Dr. Ellingson, was supposed to talk in the next part about young hip pain, and again, he got called to the operating room. So I'll talk a little bit about that. Not all hip pain is hip arthritis. Other conditions are labral tears, and we do surgery on those here for Virginia General as well, using arthroscopy towers in the same type of room and the same table. So we're happy to see any patient that has hip pain, regardless of your age, at OrthoVirginia. And again, we're located in Virginia Beach, about a block here from the hospital. So now I'd like to take some questions if anybody has any.
Yes, there are some questions. So I'm Rich Loftus, off camera, also with OrthoVirginia, and I'm going to relate the questions to Dr. Lambert, and then let's get some answers. Dr. Lambert, what is the usual recovery time after a hip replacement surgery?
Highly dependent on the patient. What is the recovery time is the question. So some patients can recover as quickly as 3 to 4 weeks. Most patients take about 6 weeks to recover. What do I mean by recovery? My goal for all of my hip replacement patients is when they come back and see me at the 6 weeks appointment after surgery that they're walking with no cane, no crutch, no limp, and on no pain meds. I will say that having the left hip replaced takes a little longer to recover from, specifically, the right, specifically with driving. So the brake foot is important in driving, obviously. So we don't like our patients to drive until they're comfortable getting from the gas to the brake. We have a manual transmission, and left or right shouldn't make a difference. But overall, it's about 6 weeks. Some people prefer.
There is someone who wants to know, she lives in DC. If she were to travel to Virginia Beach for a hip replacement surgery, how long before she could safely travel home?
Well, I've had a lot of experience in operating on patients from out of town. When I was in the Navy, we had people flying over from Europe to have it done. There are some risks to driving back after surgery, but with today's technology and some of the medicines, we have minimized those. I would prefer that my patients who are coming from out of town stay overnight here in the hospital with us, and if everything looks good, if it's within driving distance, the earliest we want to get them back home is one day, but preferably we'd like to have them stay in the area for a few days.
What are some of the solutions for bursitis?
So, bursitis is different than arthritis, although they sound a lot alike. I want to talk a little bit about the difference in what they are. So hip arthritis generally involves pain in the groin or the front of the hip. Most people get confused. They feel like they have a groin pull, and really that's the hip joint in the front. Bursitis, which is what the question is about, is located laterally on the point of the hip. And the bursa is a sac of fluid right over the bone. It's called the trochanter, the area of the femur, and it gets inflamed with the muscles pulling on it. The treatment for bursitis is almost always no surgery. Physical therapy is the cornerstone of treatment. We use a lot of therapy in our practice to help treat this. In addition, you can get an injection into the side of the hip to help reduce bursitis.
Can you discuss the timeline for physical therapy post-surgery, post-hip surgery?
So for hip replacement, physical therapy has changed a lot recently. We have a wide range of patients. For some young patients, honestly, they get physical therapy in the hospital and then they do the rest on their own. This is not like a knee replacement. A knee replacement requires intense therapy with a lot of bending and a lot of supervision. Hip replacement, basically walk. We give you some home exercises to do. So on the short end, people get minimal therapy, and on the long end, patients go to physical therapy 2 to 3 times a week for up to 6 weeks, and then that's usually more than enough. So a lot of this depends on how much of a self-starter the patient is. If you're able to do the exercises on your own, you can do them on your own. If you need supervision, or like myself, you need a little more motivation, you might be better off with a therapist.
We have a question regarding prevention, and the question is, what is the best exercise or stretching routine to prevent problems in hip pain, particularly for someone in their 60s?
So there are a lot of exercises that can be done to prevent pain. Prevention is much better than going through this big surgery that I love to do, but if we all did the prevention, we wouldn't need it at all. So there are many types of exercises that can be done, and I'd be more than happy to see each individual patient and give them a prescription for therapy so they can do them. So simple lateral, straight leg raises, things we call clamshells, and we can give you a list of exercises, but it is very important that a qualified therapist observe you do the exercise. If you do it correctly, it will work and make a big difference for you. If you're doing them incorrectly, it can actually exacerbate the problem. So a one-time visit can help us get your diagnosis, and then we can prescribe the therapy either on your own or with a therapist.
There is someone who experiences hip pain when sleeping on their side, but both sides hurt. Is that sciatic nerve issue or possibly a hip issue?
It could be a hip issue. So I'll tell you, most of my patients that I evaluate in the office are oftentimes back pain patients, and they're coming in because they think it's their hip. So it could be either one. Back pain usually occurs in the buttock area, back here. That's for kind of the traditional sciatica. Hip pain again is in the groin on the front, and then bursitis, which is part of the hip, is usually on the side. People telling me they hurt the lie on their side, and that usually indicates that bursitis, which is a problem with the hip. However, it's good to come in and get a diagnosis, X-ray, physical exam, and once we have your diagnosis, we can discuss together what kind of treatment is best for
I'm going to bring the camera and the microphone a little bit closer to you so that we can handle this round of questions. When both hips need to be replaced, what's the length of time between those two replacements?
So that's an interesting question. I have done many different ways. The easiest way is we do one hip replacement, and the patient fully recovers, probably about 3 months. And then if the patient and I are still on speaking terms, we go back to the other hip, and we do the same process again. So generally 3 months. However, I've had a lot of patients that get one side done, and they feel good with one good leg and one bad leg, and they go years, depending on their life circumstances. On the far other end of the spectrum, on a very particular patient who's very healthy and who has some specific criteria, we can do them both at the same time, and I have done them right here at Beach General pretty successfully, but it's a very specialized patient who's able to go through 2 surgeries at the same time and recover well.
Thank you. Some questions were submitted even before the presentation began. Let me give them to you as sort of a lightning round. Can anything be done with scar tissue after having surgery?
So there are some techniques that can be done both in physical therapy and topical treatments. As far as scar tissue around the hip, we don't see as much of it as we do around the knee. Hip stiffness and scarring is not nearly as common. In general, when we have scar tissue after surgery, our treatment is to cut it out. Unfortunately, sometimes it does grow back. There's a certain type of scar tissue called heterotopic ossification, in which the muscle turns into bone. It can be a bit of a problem for patients around the hip. In addition to cutting it out, there are some radiation therapies that can be done for that. But again, it's very rare around the hip to have a lot of scar tissue.
Can you recommend an appropriate preventive treatment for a 66-year-old female with osteopenia in one hip and osteoporosis in the other?
So in general, older women, postmenopausal women, have trouble with bone quality. So it's important for all older women to practice good bone health. And the number one thing you can do is to participate in some impact exercise. Simple walking, even more so weight training. This helps to keep the bone healthy. In addition, a normal intake of vitamin D and calcium should be a very good start for preventing osteopenia and osteoporosis. In addition to that, there are some very exciting new medicines out to help treat the more severe cases of this. You should follow up with your doctor to get specific information for your case.
Could you restate some of the basic preventive measures for people to avoid hip pain?
So, preventive measures to avoid hip pain. Number one, weight loss. If everyone could achieve an optimal weight, that would make a hip surgeon's life a lot easier. So the less weight that comes across a joint, the better, whether it's the hip or the knee. It's very difficult when you have a bad joint to lose weight. However, it still can be done with that. So number one preventive measure to prevent hip pain or hip arthritis is weight loss. Number two, maintaining the range of motion. This can be done through normal exercises in the gym or some formal physical therapy. They are good for maintaining the motion. And number three, maintaining strength of the muscles around the joint. So that, again, is exercise and sometimes formal physical therapy to fight, as you get older, something called sarcopenia, which causes the muscles to wither away as we age.
Here's a fairly specific question. Is there a connection between hip issues and spine L3S1?
There are absolutely connections between the hip and the spine. So all of the parts of your body are connected. We try to zero in on the part that's causing most of the problems. And in general, the back can cause problems with the hips, and the hips can cause problems with the back. So figuring out which one is the so-called pain generator is one of the things I do every day in the office. And it can be challenging. There are many techniques we use to determine, is this pain coming from someone's back or is it coming from their hip? Everything is simple as a simple history and physical examination, to x-rays and MRIs, as well as injections can help sort this issue out. But they are definitely interrelated.
Can you discuss the material that the hip device is made of?
Yes. So these are the imprints, okay? So I don't know if you can see this okay. This is made out of titanium, and it's what's called porous coated. So the inside's smooth and the outside's a roughened surface. And these beads were put in the factory, and they're a very specific size. The bone grows right into it. So this is called a press fit, meaning we don't need any cement or glue. And the bone grows right into it, and that means you get to keep it forever. That's the acetabulate component. Inside of the shell is the plastic. This is the part that will wear out someday. We've gotten a lot better, and these parts are very advanced. The lifespan of a hip replacement is 20 plus years. However, the weak spot is still the plastic, and this is the one that will eventually wear out. It snaps into the titanium shell and becomes one piece. That's the acetabular side. This is the femoral side, also made out of the same titanium. It has the same coat here, and it's also covered with a substance called hydroxyapatite. This is a chemical that attracts the bone, so the bone will grow into it. The ball that we use on top of the stem is made out of ceramic, and it snaps in with a Morse taper. Okay. And then we put it all together, and the bearing surface is now ceramic on plastic.
Thank you. Here's a question by someone who asks, do patients who have been through a strong chemotherapy regime have issues with arthritis?
So that's a good question. Do patients who have had chemotherapy have problems with arthritis? So first of all, you can have cancer and arthritis at the same time, so the answer is yes. Some chemotherapeutic agents can damage the joint, and so they do have a little bit of a cause, some of them. Some chemotherapeutic agents just cause pain around the joint, which is not related to arthritis. So, and there are a lot of new medicines out to treat cancers, and we've made great advances. So for each individual patient, you have to follow up with your doctor to find out if one is causing the other or if they are related.
Dr. Lambert, do you treat patients with complicated health?
I do. So as an arthritis surgeon, not everyone over the age of 65 is healthy. As a matter of fact, most of them are not. And there are some significant complications that we deal with here in my practice at OrthoVirginia and here at Virginia Beach General. I have a patient here in the hospital today that is 88 with a complex fracture and a complex heart problem at the same time. Luckily, we have a great team of doctors where one can take care of the hip and knee, which I do, and then the other ones can take care of the heart, and we work together to come up with a good plan for the patient overall. It takes a lot more than one person to care for the patient with a lot of medical problems.
Okay, and two questions that you've answered somewhat in a few moments ago. George wants to know, can the plastic liner be replaced?
Yes, it can. So what the question is, when I said the plastic wears out, the question is, well, can we go in and leave the metal part in the bone and just switch the plastic out? And the answer is yes. It's called a polyethylene exchange or a poly swap. And it is a revision surgery, but it is a pretty quick recovery, and we do these all the time. So yes, you can exchange just the one part that's worn out and put another one in. And that is a common procedure that's done right here at Virginia General by me.
Very cool, thank you. Also, someone missed the short response to the time period between dual hip replacements.
So the question is about have arthritis in both hips. How long do you wait from getting one replaced to the other? The short answer is 3 months, but it depends on the patient. Some patients will have one hip that's arthritic, they get it replaced, they're very happy, and they keep their one good hip and one bad hip for many years. Other patients are in such a hurry and they meet very specific criteria that they decide to get them both done at the same time. Same surgery, one day, both hips replaced. I do that rarely, But in special occasions, we will do it. In the majority of my patients, 3-month wait. Between hip replacements.
Someone is watching who is in their second year after post-hip replacement, and they're experiencing significant pain. What should they do?
So pain after hip replacement does occur. It's not common. I'd say probably less than 5%. But as a specialist in hip replacement, I tend to see a lot of those patients, both done by me and a lot by other surgeons. So the first thing you should do is you come see your orthopedic surgeon. There's many things that could be wrong, and everything might be fine and we might not come up with an answer, but it deserves a thorough workup with a history, physical examination, some x-rays, and maybe some lab work to determine what needs to be done for you.
Fantastic. Again, people are fascinated by the materials of the hip replacement. So the plastic piece might last 20 years and the titanium piece forever.
The idea is that the titanium piece will last forever. However, there are some complications that require for it to be pulled out. An infection, a fracture of the bone around the implant. But once that bone grows into it, unless you have one of those two, it should last forever. The plastic's the one that usually wears out. The titanium does not wear out.
Dr. Chris Ellingson is back, and perhaps some of you have questions for him related to young hips, hip pain, bursitis. Focus on Chris.
Hey, good to be back. Sorry to step out there for a minute. And we talked about hip arthroplasty. Should I discuss hip arthroscopy briefly while we get some more questions coming in?
Yes, you're going to do it.
So one of the things that I do as a sports orthopedic surgeon is perform hip arthroscopy, which is a much different surgery, obviously, than the hip arthroplasty. A hip arthroscopy, or hip scope, if you will, is a surgery that's performed through small incisions utilizing a camera. I have it right here. A camera such as this. This is a striker camera that we have here today, but it has a light and a lens at the end, which allow me to go through small incisions into a joint and do work within the joint. I do hip arthroscopy for conditions such as hip labral tears or hip femoral acetabular impingement, or FAI. That's a condition where the hip comes up and bumps against the edge of the socket and creates tears of the cartilage or the labrum. And so those patients tend to have deep anterior hip pain, particularly in a squatted position or while sitting, and certainly is one of the continuum of hip disorders that I treat in the office and in surgery. Do you have any questions, Rich? Or?
At the moment, there is a question for Dr. Lambert that is related to a hip replacement. Someone whose leg in which there was a hip replacement is now longer than the opposite leg.
So that's a problem, and one of the things we were demonstrating earlier is all of the lengths we go to in the surgery to prevent this problem. So when I do a hip replacement, I think about the leg length every second of the surgery. We're using a lot of technology to get it within millimeters. However, sometimes it doesn't work out that way. And I have had patients sent to me from other surgeons with legs that are longer or shorter. So that is a problem that can cause patients pain. It can cause back pain from the way they're walking. There are many treatments for it. One is a simple one, like a heel lift in the other shoe to even things out. That's easy for the patient, and if it works, that's what we try to do in most cases. Other treatments are a little more complex and would require a long conversation in the office. I'd be happy to evaluate anybody that has that problem in the office.
Jennifer wants to know, what is the wait time for a hip replacement surgery?
You'll have to ask my scheduler, but I'd say probably about a month or so. We try to get them in as soon as you need it.
Okay, now, a few questions for Dr. Ellingson. What is the recovery time after arthroscopy?
So after hip arthroscopy, you're allowed to place weight on your foot right away. You do have crutches for the first month to offload the leg, but we try to get you to walk with a relatively normal gait during that time. Patients are usually on a stationary bike doing physical therapy within 3 to 4 weeks of the surgery. By about 5 or 6 weeks out, we expect you to be walking normally, doing your normal daily activities. As you progress with physical therapy, we get you onto the the elliptical machine, working on strengthening and conditioning. Most folks, we don't recommend any kind of impact activities, so jogging and those type of things until at least 4 or 5 months out from surgery. And in general, I discuss with my patients it's an overall a 6-month process after hip arthroscopy to get back to hopefully normal function and feeling fully recovered.
There is a question about hip replacement for Dr. Lambert. What do you suggest for someone who also needs a spinal fusion who can't walk as far after a hip replacement?
So spinal fusions and hip arthritis go together like peanut butter and jelly. I see a lot of patients that need both, have had a spinal fusion, need a hip replacement, or have a hip replacement, need a spinal fusion. So they do go together a lot. One of the interesting things about the spine-hip relationship that has really become popular in the orthopedic total hip community is when you fuse the spine, most of the motion that used to be in the spine goes into the hip. So those patients are at risk for something called a dislocation, in which the hip pops out of socket after it's been replaced. Many things to prevent that. Some of the modern devices we use help prevent it. The anterior approach helps prevent it. But this is a relationship that we as surgeons are paying a lot more attention to. Spine arthritis needing a spine fusion, and hip arthritis needing a hip replacement.
Cool. And for Dr. Ellingson, a few questions that I'm going to send to you. With bursitis, if you're unable to take anti-inflammatory meds, what is recommended?
That can be a challenge. Certainly they are one of the first line treatments that we recommend for patients. I think more importantly, when we approach patients with a bursitis or an overuse type of an injury, it oftentimes comes down to some physical therapy treatments to work on overall body mechanics and strengthening. Patients oftentimes have deficits in either their strength or flexibility that lead up to the development of the bursitis itself. And so you want to get back to the source of the problem and work on any kind of mechanical issues that you could identify. There are certainly some injections that can be performed if you're not progressing with therapy type treatments in patients that are unable to take the anti-inflammatories because of another medical condition. And that's not an uncommon issue that we see in clinic with patients.
Thanks. Now, another question. Can hip arthritis mask hip adductor issues?
Yes, there's a lot of overlap with hip symptoms in general, and that can be one of the challenging aspects of evaluating patients with hip pain or pain around the hip area. And there can be overlap in conditions that occur in a simultaneous fashion. So hip arthritis can be concurrent with hip adductor tendonitis. Usually you're able to differentiate the two during the examination in terms of some certain maneuvers that we can perform, but also generally in just speaking with the patient, getting a good history of what their symptoms are like, when they occur, what activities make them worse. We can usually kind of differentiate out those different conditions.
Dr. Lambert, this is for you. Dr. Ellingson, another question just came in. Could you please explain just once more how to tell the difference between arthritis pain, bursitis pain, and hip pain that's related to the back?
Oh, yeah. So that's a complicated question. It's a good question. And again, it kind of speaks to some of the overlap that we see in patient symptoms and conditions. In general, back pain or pain related to the back that travels down around the hip region tends to be more posterior in nature. And so if somebody's having symptoms that are more posterior in the low back or posterior in the low hip, that is more consistent with a back issue. In terms of hip arthritis, those patients are normally describing more anterior or deep joint pain. That pain tends to be somewhat chronic in nature, more of an achy type sensation. With bursitis type of pain, it can be variable depending on what type of bursitis you're dealing with. But that generally tends to be a little bit more of a more superficial type of pain that's reproduced in clinic on examination with certain palpation and maneuvers.
Okay. Now, a question for Dr. Lambert. Do you do a posterior or anterior incision in your surgeries?
So for hip replacement, I do the anterior approach, which is in the front, separating the muscles, not cutting them. The posterior approach is an incision in the back. And I did that approach for about the first 8 years of my career. And it worked out very well, and that approach continues to do well. However, there are a couple problems with it. Number one is the dislocation rate. The hip popping out of socket. With the posterior approach, the rate is higher. I was very good at doing the posterior approach, but my rate was still higher than I wanted it to be. So the anterior approach, the dislocation rate is much lower. So that's the first advantage of the anterior approach. The second advantage is a little bit quicker recovery. Patients get up quick, they go home the next day, and they do very well with that. I would say one-third advantage that we don't talk about much is during the surgery, some of the technology that we were talking about earlier, being able to get an x-ray during the surgery before the patient's even awake is unique to the anterior approach and some of the special equipment we have, which gives me a warm sense of confidence when I'm putting the hips in, better so than the posterior approach. So I'm the anterior approach surgeon.
Now, I'll ask a final question of you, and our apologies to anyone whose question could not be answered. I'll work with the physicians and see if answers can be given and posted to this page after the event. So the final question is, for either surgeon, can you talk about recent studies and results on using platelet-rich plasma? What does that mean to your casework? To your patients?
I'll take that one. As a sports guy, I probably have more experience with the PRP than Dr. Lambert does. So platelet-rich plasma, for those of you who may not be familiar with it, is essentially taking some of the patient's own blood, spinning it down in the centrifuge, getting rid of the red blood cells, and keeping the plasma, which is high in platelet concentration and other chemical factors. Depending on how you prepare that, how you spin it down, and what to take off, it can be used for anti-inflammatory properties in terms of injections intra-articularly, but also, more importantly, for treatment of different tendinitis and tendinopathies. And the majority of the literature that is currently present for PRP injections pertains to treatment of tendinopathy. And one of the most frequent tendinopathies involved is simple tennis elbow or lateral epicondylitis. And there have been some studies that show that PRP injections along that tendon that's damaged can reduce inflammation and promote healing. We've extrapolated that into many other conditions, and so we are using PRP injections in other tendons that are injured. We use it in inflammatory conditions to help decrease inflammation and promote healing. And there are some intra-articular injections being done for patients who have mild arthritis or inflammation. Some of the studies on that are still kind of pending, and certainly we continue to follow the literature to see what the injections are useful for. And what type of injection, because there are different types of PRP injections that can be used, are most useful for these different conditions.
Fantastic. Well, thanks, and I will let you say farewell to the audience, gentlemen.
Thank you very much for tuning in on our special on hip pain. Come and visit us at OrthoVirginia, and we look forward to meeting all of you soon.
Thanks to everyone for visiting, and I'm working on audio issues. We're going to test out a new microphone and camera, and you'll experience that in our next Facebook Live.